And this is Chapter 35, Geriatric Emergencies. Geriatric patients, though a smaller part of the population, will make up a tremendous amount of the patients we see in the field because of course, the medical problems that go along with aging. So it's important to understand, appreciate how the life of an older person might differ from yours. Keep in mind, some of these people are struggling with different issues. Perhaps they've lost a spouse and they have to fill in for that spouse's role, whether it be managing the finances, doing the grocery shopping, um, home and yard maintenance. They're struggling taking care of that. They also um, have fixed incomes, and trying to live on fixed incomes, especially with annually rising prices, can be a challenge for them. So a lot of them may choose to pick and choose what medications they take or take them intermittently, and that never works out very well. They are struggling to remain as independent as possible for as long as possible. They a lot of times will still live in the homes that they raised their children in. Maybe it's sentimental reasons, maybe it's something where they feel that they want their children to feel free to come back home, and maintain that home thing. And of course, we live in a real mobile society, and most of you can probably relate to this already in the fact that you live away from your parents. And even if perhaps like an elderly couple live here in Kitsap County, but their children live in Seattle or in Tacoma, they're not immediately there to help. So that's always kind of a challenge. You want to be patient when you interact with them. Treat them with patience, respect, and we'll talk about that a little bit more later. But also try to avoid ageism. Um, you know, Ageism is stereotyping older people that leads to discrimination. Keep in mind, older people can stay fit and be active. In fact, we have people that stay active well into their 70s and 80s, even though they're not able to perform at the same level as they did with their youth. As youth, leads them to retire as firefighters. Effective communication skills are essential to the assessment and treatment of the elderly. Keep in mind that the aging process brings on changes in vision and hearing. It also brings on changes, of course, in taste, smell, touch, and pain sensations. All these are part of the assessment process or leads the patient to not getting help quickly. But again, changes in vision, hearing, and changes in communication abilities accompany aging, especially when it comes to stuff like dementia or other diseases. Keep in mind, you can even have acute changes from morning to afternoon, from the night before to the next morning, in cases like urinary tract infections, stroke, decrease in blood sugar. So your first words to the patient and the attitude behind them can gain or lose a patient's respect right away, or their trust. Be respectful, introduce yourself. Let them know who you are and why you're there. So be aware how you present yourself. Make sure that you're on the same level as they are. A lot of these patients are going to be sitting down or they're going to be in bed. You want to maybe get down on a knee so you're talking to them eye to eye. That also helps them see your lips to help them pick up visual cues of speech, and also helps with their hearing. Speak slowly and distinctly. Now keep in mind that in aging, the organs of hearing, in particular the cochlea, kind of wears out. what I mean by that is inside the cochlea is, by the way, the cochlea is the organ. It's kind of a seashell shaped organ. And inside there's cilia. These are hair-like projections that are attached to auditory nerves, the nerves of hearing. And the cilia are actually have different lengths, and the length of the cilia determines the frequency of the sound that's heard. Now, the shorter cilia, the shorter hair-like projections, pick up higher pitch, and the longer ones pick up lower pitch. So the shorter ones tend to wear out earlier. So even as early as your 30s, you can start having a wearing out of these fine hair-like projections. And so you don't pick up high pitches like you would if you're younger. So an effective technique of communicating with the elderly is to lower the pitch of your voice and increase the volume. You'd be amazed how well that works. Now, have one person talk to the patient and ask only one question at a time. Don't be pelting this poor elderly person with questions from 2 or 3 people. One person asking history, one person asking their date of birth, one person asking, their medications, their allergies. So one person talking, letting them focus on you. Now, again, don't assume that all of them are hard of hearing. Some of them have very good hearing. But give them time to respond. Sometimes they have to formulate an answer. Sometimes they want to describe something or recall something. That takes a little bit of time. Be patient. Listen to the answer. Write it down so you can avoid asking the same question twice. And with these people, you need to explain what you're going to do before you do it. If you're going to take a blood pressure, Mr. McGillicuddy, may I take your blood pressure? I'm going to wrap this around your arm. So, again, especially if they have a little bit of an altered mental status, something like this could, doing stuff without announcing it to them or explaining it to them can startle them and actually irritate them and start moving the call in a bad direction. You want to be very careful of that. Geriatric patients are predisposed to problems that, of course, aren't seen during youth. A simple rib fracture in an 80 or 90-year-old can result in pneumonia or even death. Now think about that. If they fracture a rib, already most of them have, or a lot of them have, a decreased tidal volume. But to have that further decreased with the pain of a rib fracture, or them not being able to give an adequate cough to cough up phlegm because of a rib fracture, they tend to develop pneumonias. And pneumonia is a serious issue and a common cause of death in the elderly. Now, hip fractures from what we would consider a low mechanism fall, just tripping over their schnauzer, Thomas Horatio Bixby II. They fall and they can fracture their hip. Bones are weakened by osteoporosis or infection or some of the other things that we talked about the other day. They may be on steroids that weaken their bones. They may have had some chemotherapy or radiation therapy that have weakened their bones. And a lot of them have a sedentary lifestyle. Hey, we've been cooped up. We're going through at the time that I'm preparing this lecture, we're going through the COVID-19 stay-at-home shelter-in-place type experience. And so a lot of us have become sedentary. You know, we're seeing that, we're gaining weight, and but that sedentary lifestyle continuously over months in these elderly can um, predispose them to stuff like pneumonia or blood clots. Many elderly people are well aware of these situations, and it can cause some fright. So again, they fear losing independence. They fear not being able to walk. They fear being bedridden over an amount of time. They've had friends that have gotten pneumonia who have died. So you have to be conscious of all this and have a positive attitude towards their treatment. Very important, that positive attitude in treating the elderly. Now, these are just some of the common conditions that we see in the elderly. Hypertension, the high blood pressure, of course. Arthritis, both osteoarthritis, which kind of goes along with age and deteriorates naturally the joints, as well as rheumatoid arthritis, which is one of the connective tissue diseases that we see, kind of akin to lupus and scleroderma. Also, heart diseases, cancer, of course, diabetes, type 2 diabetes, very commonly, which then can exacerbate all these other issues, asthma, emphysema, and leading causes of death, of course, heart disease and cancer. The chronic lower respiratory diseases, which include chronic bronchitis, pulmonary hypertension. Of course, we have stroke, Alzheimer's, and then influenza and pneumonia that can wipe them out. And again, we see in these, especially in these epidemic and pandemic issues, we see that it's the elderly that are taking the hit as far as dying from these issues and these diseases. So age-related changes can predispose an older adult to respiratory illnesses. Now, airway musculature become weakened. And when we're talking about the respiratory musculature, we're talking about the intercostal muscles, the sternocleidomastoidal muscles. These become weakened. Again, and a lot of people don't respect some of the things that elderly people can do to really prolong this. And so walking, exercise, light weightlifting, yoga can all strengthen those muscles. The alveoli in the lung tissue becomes enlarged, and the elasticity of the alveoli decreases, especially if they are sedentary, but even more if they're smokers, if they live in areas that have high air pollution. Something to think about. The body's chemoreceptors. Now, chemoreceptors are the receptors that pick up on the changes in, mainly for breathing, is carbon dioxide. And so the chemoreceptors pick up the changes in carbon dioxide and tells us when to breathe and how much to breathe. Those slow with age too. Now, pneumonia, is an inflammation or infection of the lung from bacterial, viral, or fungal causes. And it's one of the leading causes of death in Americans over age 65. It affects the people who are immunosuppressed associated with aging and increases the risk of contracting pneumonia. Now remember, some of the things here too, when we're talking about pneumonia, is again the patient that tends to be sedentary, patients who have immunosuppression. Again, There's some of those diseases that we talked about, uh, rheumatoid arthritis, lupus. There's a couple other immunosuppressant diseases. Or if they're receiving therapies, especially for, say, like cancer, that leaves them immunosuppressed. Some of the steroid treatments that are being used for uh, asthma, emphysema, those will reduce the immunosuppression response. So these are patients that are at risk of contracting pneumonia. Pulmonary embolism is that condition that causes a sudden blockage of an artery by a venous clot. Now, a lot of times these are caused by sedentary lifestyle. And that sedentary lifestyle could be exacerbated by smoking. That would cause these blood clots. Another thing would be that patient with atrial fibrillation. Atrial fibrillation tends to cause blood clots, and they may or may not be on blood thinners for that. So these patients will present with shortness of breath, sometimes chest pain. The chest pain will come on quickly. It'll be a marked shortness of breath. They may be pale. They may have some cyanosis, especially in the fingernail beds. We give them oxygen and their O2 saturation, which starts out low, doesn't improve. So that's a patient that we continue to high flow oxygen and transport them immediately into the emergency department. In the emergency department, they'll do a very quick radiological exam and then normally start them on thrombolytics, a lot like we would, say, for a myocardial infarction, and then have them on blood thinners and watch them fairly quickly. On rare occasions, they may choose to do surgery on pulmonary embolisms. So let's talk about some changes in the cardiovascular system. The heart hypertrophies with age, meaning that it enlarges and the effectiveness of each beat of the heart is decreased. Let's talk about just a couple terms. The first term is afterload. So we have preload, that's the amount that is put into the heart that's ready to be pushed out of the heart. So that's preload. Afterload is what's left inside of the heart after the contraction of either the atria or the ventricles. Now, remember, stroke volume is the amount of blood pushed out with each contraction of the heart. So as the heart hypertrophies, as it becomes larger and weaker, it's normally because of the stiffening of the blood vessels. So as the heart tries to push blood out, it's pushing against a hardened and more narrow blood vessel. And so it increases the afterload. So there's still going to be a lot of blood left in the heart chamber at the end of the heartbeat. So when we keep doing that time and time again, it's going to increase an extra burden on the heart and wear the heart out. And that's where we start getting one of the causes of heart failure, and this is congestive heart failure. So in the geriatric patient, they're at risk for atherosclerosis. So the basic pathology of this is, the ability to speed up contraction, increase contraction strength, and constrict narrow blood vessels is decreased because of the stiffer vessels. So normally what happens is, as you see in that lower picture, you see a buildup of plaque in calcium. And the plaque being made up of cholesterol, and that hardens the artery. So it makes the stroke volume, the less effective. So this is what makes the possibility of a bowel infarction, not enough blood going into um, the vessels around the bowels, and they become infarcted. Hypertension, the high blood pressure. This is what causes it, along with heart disease and the possibility of stroke. Also, the geriatric patient, the elderly patient, has an increase of formation of aneurysms. That's that weakening in the arterial vessel wall that can rupture and lead to severe blood loss. The blood vessels themselves become stiff, which results in a higher systolic blood pressure. Again, keep in mind too that high blood pressure just doesn't affect the cardiovascular system, but it also affects the renal system. So the glomeruli, the structures, the working structures inside the kidneys can become degraded and actually destroyed because of high blood pressure and could lead to renal failure. Stiffening and degeneration of the heart valves, they may impede normal blood flow in and out of the heart as they become less effective. The electrical conduction system of the heart undergoes changes leading to either abnormal heart rates, slow or fast or irregular. So venous stasis when we talk about stasis, it's normally just a slowing of the reaction of the veins, or the slowing of allowable blood flow. So it can lead to loss of proper function of the veins in the legs. It can also lead to deep vein thrombosis. These are blood clots that can then break off and then travel up and cause pulmonary embolism. Orthostatic hypotension, you guys know, is a drop in blood pressure with a change in position, either from lying down to sitting up or sitting down to standing. And it makes the body less able to adapt to rapid postural changes, certainly an issue in venous stasis. Also, venous stasis can cause, lack of blood flowing back into the heart. So this is just another problem that we see in the elderly. Now, when it comes to heart attack, myocardial infarction, sometimes those classic signs of chest pain, shortness of breath, pain moving up to the jaw and arms, they may not be present. Now, keep in mind that, especially if they're postmenopausal women or they have a history of diabetes, some of those nerve pathways can be affected, and so they're not going to have the typical signs of myocardial infarction. So their signs and symptoms may be like we've described in the past, very tired with minimal exercise. That woman that I described perhaps one time that went out to her mailbox to get her mail, or to take her dog out to tinkle, comes back and she's just overwhelmingly tired. That person who just doesn't feel right, maybe has a little bit of an upset stomach. You have to look for signs and be suspicious of myocardial infarction in those elderly patients with those unusual signs. So heart failure, we've talked about this in the past. The signs and symptoms will differ whether it's from the right side of the heart or the left side of the heart. So in the right side of the heart, keep in mind, the right side of the heart is receiving blood from the body. So if we have right-sided heart failure, meaning the heart isn't able to push the blood through, it's going to back up. It's going back up in the body. So what are we going to see? We're going to see jugular vein distension. We may see dependent edema. When we say dependent edema, if the person primarily sits around all day, they're going to have swelling in their ankles. When we look at left side heart failure, this is where again, the left side of the heart receives blood from the lungs. So the fluid is backing up into the lungs, and that's where they'll have shortness of breath. The paroxysmal nocturnal dyspnea attacks the respiratory with respiratory distress, and the patient is awakened from sleep. Now, keep in mind, this is a group of people that we're going to be called in the middle of the night for them having shortness of breath. And that shortness of breath is going to worsen when they lay down. The worsening of shortness of breath when they're laying down is a term called orthopnea. So when they're lying down, their shortness of breath increases. So we certainly want to take a look at that and treat appropriately. And by the way, the patient who is awake and breathing and can answer questions, the treatment for heart failure, now for EMTs, is CPAP. Stroke is a leading cause of death in the elderly. Now, there are some preventable factors, such as smoking, diabetes, controlling the diabetes, especially type 2 diabetes. Remember, type 2 diabetes can be pretty easily controlled with weight loss, increase of activity, and careful diet. Normally a diet that's a little bit lower in complex carbohydrates, bread, rice, potatoes, any processed foods. Obesity, lack of exercise, and reducing the blood pressure, and normally it's doing all of this, including taking medications. Of course, there's some uncontrollable factors such as age. The older we get, again, we get into some of those atherosclerotic issues. Gender, men tend to have higher chances of stroke. Race is an issue. Patients, African Americans, basically the minorities tend to have a higher incidence of stroke. So again, let's look at the signs and symptoms of stroke very quickly. It could be altered mental status, but more commonly we see unilateral weakness, weakness on one side of the body, slurring of speech. So we go over the FAST exam. Facial, we have them smile. If they're weak on one side, they're going to droop on that one side of the face. Arm drift, again, we have the arms out, palms facing to the ceiling, and we look for either pronation of the thumb or a dropping of the arm. Next, we look at speech. We have them repeat a simple sentence. I like, "You can't teach an old dog new tricks." Other people use other sentences. I use that one, "You can't teach an old dog new tricks," because it uses all the muscles of the mouth and tongue. And we look for slurring. Now again, if you can't tell whether they're slurring or not, and you have a family member there that could kind of tell you if they're slurring, ask them, does this sound right to you? And they'll say, nah, sounds like they're slurring a little bit. And then, of course, then we want to know time. So the time lasts normal. And please try to get a clock time. Don't get about 15 minutes ago. Try to get a clock time if you can. Physicians can get pretty hung up on that in the ER. Hemorrhagic strokes, that's the one that's bleeding inside the brain. A blood vessel breaks inside the brain. They're less common, but they're more likely to be fatal. So these are patients that will have stroke symptoms, but may also have headache. They're more apt to have changes in their blood pressure. We're going to be looking for those changes in the blood pressure that we would see in a head injury. The increase in the systolic blood pressure, a slowing of the pulse rate in the later stages of hemorrhagic stroke. Ischemic strokes, again, that's where the clot is formed, and they make up the lion's share of strokes, and that blocks the blood flow into a portion of the brain that gives us our stroke symptoms. Now, if the patient's symptoms present within the past few hours, we've expanded that now, somewhere to between 8 and 12. The patient is going to be a candidate for stroke center therapy. So, fortunately, Harrison, our local hospital, is a stroke center. Call ahead, and these are patients that we don't even take them off the stretcher in the ER. They're examined right there in the emergency department, and we wheel them right back to radiology. The doctor will do a quick once over, gives us a thumbs up, we take them to radiology, and they have a CT scan to determine whether it's a bleed or not, and then they can confidently use thrombolytics to clear any blockage. And that's especially for the embolic stroke. Now, a transischemic attack can present with the same signs and symptoms of a stroke. These normally clear within 24 hours. And it's not unusual to start out with a patient having stroke symptoms, and by the time you get them to the hospital, they get better. So let's kind of talk about the etiology of that. So keep in mind that we talked earlier about how plaque and calcium develop inside vessels. Now, keep in mind that these just aren't peculiar to the vessels of the torso and the extremities. That also affects the vessels of the brain. So imagine the vessels inside the brain that have some buildup of plaque in them. Now remember, vessels are not plastic. They're dynamic. They constrict and they dilate. So in some cases where you have a patient that has some arteriosclerosis inside their cerebral vessels, the vessels of the head, and those vessels constrict and maintain constriction for some time, it could then give some symptoms of a stroke. Then, as the vessels dilate and blood flow returns, sometimes it's not right away, those symptoms resolve and the patient comes back to normal. That's one pathology of transischemic attack. Another one would be just small clots that will temporarily block an area and then flow through. So those are a couple of the etiologies and pathologies around transischemic attack. So again, we treat them the same. Make sure that we get a good time, we do a good fast test, and we report that into the emergency department. So let's talk about some changes in the nervous system. Now, as a person ages, they tend to have changes, of course, in thinking. Thought processes don't come as automatically, as you notice in a lot of my lectures. There's changes in their memory. They don't remember stuff. unfortunately, I'm at that point where, if I learn something new, I have to forget something, and I'm right down to my kids' names. So, but they normally have a slower response to questions. Again, that's why we give them a little bit of time to think. The brain decreases in weight, and keep in mind also decreases in size. And we're not talking, you know, centimeters. We're talking, micrometers, sometimes, millimeters. And the performance of most of the sense organs decline. Their taste of smell, their sense of smell, their sense of taste and hearing. They decline. So, like we said, the vision decreases, visual acuity and depth perception. Of course, they can develop cataracts, and these can be, of course, easily cleared. Decreased tear production, either naturally or because of other disease processes, like in some of your connective tissue diseases like scleroderma, rheumatoid arthritis. They may develop something like Sjogren's syndrome that decreases tear production. They have a presbyopia where they have an inability to see close up, and that's why as you get older you kind of hold things away from your eyes. And then of course there's things that come along with other disease processes like diabetes that bring apart around glaucoma, high blood pressure that causes macular degeneration, and some people have actually some weaknesses in their retinas that could cause detachment and a decrease in vision. We talked about the high frequency hearing becomes difficult, but keep in mind that inside your ear, one of the pieces of the ear is called the semicircular canal. The semicircular canal is what helps us with balance. So if that becomes affected, falls will be more likely because of a lack of balance. The gradual hearing loss, again, with either age or use of different medications or some autotoxic medications, hereditary, long-term lying, and so on. Taste, number of taste buds decreases, and so the elderly patient doesn't normally enjoy food as much. And keep in mind, that taste and smell are a big thing in appetite. So if we lose these, the amount of food that's taken in is reduced, and patients may lose interest in eating and actually start losing weight. And more than most times, they'll tend to lose muscle mass. And that's where they then have that problem with respiratory muscle use. Their sense of touch and pain perception decreases, so the sensation of hot and cold becomes off. They can either be out in the hot way too long and cause heat emergencies, or in the cold too long, causing increase in frostbite or hypothermia. And because of the loss of pain perception, they may be injured and not know it. Keep in mind, that loss in sensation, especially those patients that do have a past history of stroke or have a history of diabetes. They may lose sensation to those distal areas. Dementia is that chronic, generally irreversible condition that causes a progressive loss of cognitive ability, being able to understand and see the world around them, psychomotor skills, and social skills. Now, the potential causes, now keep in mind, dementia doesn't occur over, days. It occurs over years. And stuff like Alzheimer's, Parkinson's disease, CVAs, there's some genetic factors. All of these can cause dementia. With dementia, they may have short and long-term memory loss. They have a decreased attention span. be unable to perform daily routines, so their um, activities of independent living will be affected. Uh, they'll show a decreased ability to communicate. These are patients who can appear confused or angry, impaired judgment, or just unable to vocalize pain. Now, delirium, on the other hand, is a sudden change in mental status, consciousness, or cognitive process. It's marked by the inability to focus, think logically, maintain attention. So, delirium can affect 15 to 50% of hospitalized people over the age of 70. So, again, keep in mind that delirium is normally an acute onset, meaning it comes on suddenly, as opposed to dementia that develops over time. Now, we commonly mistake delirium for dementia, but we rarely confuse dementia with delirium. The key is the sudden onset. So, these are generally caused by something that's reversible, physical ailment. So, a good case in point, I was called today for a consult on a 68-year-old male who is normally fairly active at home. And over the last 24 to 48 hours, he has been found wandering aimlessly in his yard. He is normally a fairly adept gardener. He brings weeds into the house with him, is off, just can't remember who the President of the United States is, and he loses control of his bladder. So again, this is something that's acute. It's come on suddenly over the last 24 to 48 hours. That's actually somewhat acute. And chances are this is going to be reversible. And this is something that we would see perhaps in, say, in his case, I would be guessing urinary tract infection or an inner ear infection. So we assess and manage the patient, get him to the hospital, and they'll take care of the underlying issue that's causing the delirium. Whenever we have syncope, a fainting, if you will, in an elderly patient, this is something that has to be considered serious. Don't just write it off to, oh, they fainted. There's a reason why they fainted. So syncopes, we assume it's life-threatening until proven otherwise. So it's caused, or often caused by an interruption of blood flow to the brain. And a lot of times this interruption in blood flow could be cardiac related. Case in point, 83-year-old female fell at church. She didn't trip and fall. She just fell. So the BLS crew gets there. She's awake and alert. She's not really complaining of anything. A little bit of hip pain, but she's able to bear weight. They cancel ALS, and she was out just for a little while. And they're like, okay, well, she's fine now, so we're just going to BLS her into the hospital. Well, once she was in the hospital, they went ahead and did an EKG because she fainted. She had a syncopal episode, and they found she was having a myocardial infarction. Keep in mind, the elderly don't have typical signs of myocardial infarction. They don't have those typical chest pain, shortness of breath. So this is one of the ways that it could present. So keep that in mind. Now, medication interactions can cause venous pooling, a widening of the blood vessels, and a drop in blood pressure too. We want to make sure that we also want to consider and look for hidden bleeding such as aneurysm. Look for those signs and symptoms. And then, of course, it could be a stroke or a TIA. So again, when it comes to syncope in the elderly, just don't write it off to something simple. Now, neuropathies are a disorder of the nerves and the peripheral nervous system. We see this a lot with people that have other issues. Probably the most common that we would see is diabetes. So symptoms depend on which nerves are affected and where they're located. So these could be motor nerves, sensory, or just an autonomic neuropathies that can cause decreased motility in the bowels and cause bowel obstruction. So something to be aware of there. Now, we do have changes in the gastrointestinal system. We have reduction in the volume of saliva. Now, keep in mind, saliva contains the enzyme amylase. And amylase is used to help break down food as we chew it. And then, of course, there's also dental loss. So, the elderly person isn't able to chew their food and break it down in their mouth before it goes down. Gastric secretions are reduced, in particular the acids in the stomach that help break down food. Gastric motility slows. Diseases of the bowel become evident, and they have impaired liver function. Again, all this used to break down food. And if we don't break down the food, the body can't absorb the nutrients. GI bleed can occur in either the upper or lower GI tract. It can result from inflammation, infection, obstruction. So keep in mind, so if we have an upper GI bleed, so well, let's look from both ends. So if we have vomiting of bright red blood, that could be a upper GI bleed. Or if they're vomiting coffee ground emesis, that comes from a little bit lower, so it's coming back up into the stomach and out. Keep in mind that coffee ground emesis is partially digested blood. Now let's go to the other end of the track, where if they're passing gross blood in their stool, we can imagine that being from fairly close to the rectum. So that's where the blood may be red or a bright red, and that would be a lower GI bleed close to the rectum, as opposed to tarry stools. That'll be a little bit higher up, but in the lower GI tract, and that's digested blood. So they'll have those signs. Symptoms will be weakness, signs of shock if they've lost quite a bit of blood in their gastrointestinal system, and we may need to treat them for shock. Now, there are some specific issues like diverticulitis. Now, diverticuli are little pockets that develop inside the bowels that things can get built up in their partially digested food. Seeds are a particular thing that gets caught in diverticuli. Bleeding in the upper or lower GI system, peptic ulcers that develop inside the stomach or the upper gastrointestinal system. And most peptic ulcers they find are caused by a bacteria called H. pylori. And so they can be given antibiotics for that. There's also diseases of the gallbladder that can cause pain. Now remember, where's the gallbladder located? It's tucked in right behind the liver, and they can develop some stones. And then, of course, bowel obstruction. Again, there's a decreased motility inside the bowels, and if they can't break down the food all the way, that causes obstruction, and so that could be quite serious and causing them to actually kind of vomit, kind of a smelly, well, it's poop is what it is. So ask the patient about any non-steroidal anti-inflammatory drugs that they may use, NSAIDs, stuff like ibuprofen, Motrin is an NSAID. There's a couple others that don't come to mind to me right now, but also ask about alcohol use. And remember, alcoholism is the hidden disease of the elderly. We always check orthostatic vital signs to determine if the patient is hypovolemic, and anytime we can review those. Now, you have acute abdomen and non-gastric complaints. So most serious threat from abdominal complaints are blood loss. They're difficult to assess, but the abdominal aortic aneurysm is one of the most fatal. Remember, the abdominal aorta starts from just above the diaphragm. And remember, when the diaphragm is all the way up, keep in mind it goes well under the rib cage. So the abdominal aorta starts there and goes down near the symphysis pubis, just above the symphysis pubis, and it bifurcates into the right and left femoral arteries. We also have changes in kidneys, so there's reduction in renal function, renal blood flow. Now, and there's tubule degeneration. We'll talk about each of these. So the renal function, the glomerulus, we talked about that earlier. They reduce in size and ability. Age, high blood pressure can all cause that. Reduction in renal blood flow, a lot like blood flow throughout the rest of the body. Veins become sclerotic. They stiffen. There's a decrease in blood flow, and that causes a decrease in blood filtering. So you have to kind of put all this together. So with that comes the changes in genitourinary system, where they have decreased bladder capacity and decline in sphincter muscle control. Remember, the muscle, the trigone muscle, is the muscle that is at the very top between the urinary bladder and the ureter, where we pass urine out of our body. Now, females will start having some degradation in that, normally in their early 40s. And so they'll start losing a little bit of that muscle control, and can actually pass a little bit of urine, like when they're laughing or coughing or something. So there's exercises, Kegel exercises, which both women and men can do to increase the effectiveness of the muscles around the trigone muscles there in the bladder. They decline in voiding senses, so they may urinate themselves. Increase in nocturnal voiding, that's where, of course, the patient could go into a deep enough sleep where they would lose that, and that can of course be combined with some of the medications that they take. And then benign prostatic hypertrophy that men experience, where passing urine could be a little bit more difficult. takes a little more time to empty the bladder, especially in the middle of the night when you're trying to get on an ambulance call. So incontinence, of course, then is a normal part of aging. It can lead to skin irritation and skin breakdown, especially in the bedridden person or the person that doesn't have the chance to hygienically change their underwear or their Depends undergarment. Urinary retention can cause infections. In severe cases, patients can experience some renal failure. In the endocrine system, now both men and women can experience reduction in thyroid hormones, but it seems to hit women worse, and so they tend to be on some level of hormone replacement. But signs and symptoms of decreased thyroxine is a slower heart rate, fatigue, the skin dries, the hair dries, they have a cold intolerance, and they'll tend to have an involuntary weight gain. Type 2 diabetics could experience this HHNS, this hyperosmolar, hyperglycemic, non-ketonic syndrome. And so the signs and symptoms of that would be hypotension, tachycardia, signs of shock. Their blood sugar will read greater than 600 milligrams per deciliter, and they'll have normal respiration. So remember when we talked about diabetic ketoacidosis, they have that Kussmaul respirations where in diabetic ketoacidosis they'd be breathing off the ketones. So it'd be a deep, rapid respirations. Well, in HHNS, they don't have that. Again, they'll have normal respirations. They're not trying to blow off ketones. It's non-ketonic. So that's why they don't have those Kussmaul respirations. They're not trying to blow off ketones. So that's something to look for. And it is a dangerous syndrome. It's worth having a paramedic come in. And we treat that a lot like we would the diabetic ketoacidosis anyways. We go ahead and just flood them with fluid and transport them. And this is a patient that may end up in the ICU for a couple days. Because of changes in the geriatric immune system, infections are more common. So they're less able to fight infections. They may present with anorexia. Now, when we talk about anorexia, let's not mistake that for anorexia nervosa, which is a psychological condition. Anorexia just means that they have a loss of appetite. So they may present with anorexia or a loss of appetite, fatigue, weight loss, or changes in mental status. Pneumonia and UTIs, urinary tract infections, are common in patients who are bedridden. Again, pneumonia because they're not moving very much. They may have a atrophy in their chest muscles that decreases the ability or the effectiveness of cough. UTIs, again, they're bedridden. They may actually end up losing bladder control and be in wet diapers, or if they have a urinary catheter, that can become a source of urinary tract infections. So signs and symptoms in these patients, again, may be decreased or minimized. Again, when you see the patient that's loss of appetite, change in mental status, fatigue, always look for infection. And they may not be presenting with that fever. So, be open to this. Now, because of decreased bone mass in the skeletal system, postmenopausal women will tend to have that osteoporosis or those brittle bones. Uh, Joints in the elderly lose their flexibility. And again, we talked about this before. There's a decrease in the amount of muscle mass. And that's why even, minor, or light weight training in the elderly is very important. So strength declines over time. The ligaments and the cartilage in the joints lose their elasticity, and there's an atrophy of the supporting structures of the body. And so also in the musculoskeletal system, of course, we talked about osteoporosis already. There's also osteoarthritis. Now again, that we don't want to mistake that for rheumatoid arthritis. Remember, rheumatoid arthritis is an immune system issue, a connective tissue disorder. So osteoarthritis is progressive. It's a progressive disease of the joints that destroys the cartilage and promotes the formation of bone spurs in the joint. So bone spurs, we can see them on x-rays. They're little protrusions outside of the bony area, and it leads to joint stiffness. So it affects the hands and knees, the hips, and the spine. Treatments for these are getting way better, and so there's we identify them and we help these folks. But again, these are patients that you're going to have to be a little more gentle moving, and they are also going to have issues with mobility that can cause more injury. Proteins that make the skin pliable decline, so the layer of the fat under the skin becomes thinner, the elasticity declines, so bruising and skin tears become more common. And this can be also furthered by the use of some medications, including some of the steroids. Patients who are on prednisone for a long term will have thinning of the skin, and skin tears will be more, skin will tear more easily. The same with the weakening of the vessels with steroid uses, where they bruise much more easily. And patients that are on some of the blood thinners, even aspirin on a daily basis, it'll tend to make them bruise easier. So sweat glands too don't respond as readily to heat. So these patients will have trouble getting rid of heat in the summer with perspiration. Pressure ulcers occur where you have the weight of the body that cuts off blood flow to a skin area. That's one of the reasons we don't use backboards anymore. We're getting these elderly people on these backboards, and they end up being on them for 30, 40, 60 greater minutes, and it can cause skin sores or the pressure ulcers. So with the no blood flow, the sore develops, and these can even happen if the patient isn't turned enough in bed at a nursing home or in home care. These ulcers can develop. They're painful. They're slow to heal. Sometimes they go very deep. Some need skin grafting. So we do see these, and they do weep and become infected. So we certainly want to make sure that we prevent them by padding voids and under bony prominences on the stretcher. We want our patients to be well padded on our stretchers with blankets and towels and pillows, especially when we have long transports. And that's something that you have to think about when you're dealing with long transports, is making sure these patients are very comfortable. A good case in point, I picked a woman up in Port Angeles one day, and it was just going to be a simple transport over to Virginia Mason. She's going to be admitted there for some tests and some advanced treatment. We picked her up at about 9 o'clock in the morning. I'll tell you what, she was She had just been fed, bathed. She is in a great mood. She looked great. And from Port Angeles, we went to Bainbridge Island, caught the Bainbridge Island ferry, and then from there took her up to Virginia Mason. So we're talking about a 3 to 4 hour transport. I made sure that she was padded, everything I could, but just that 4 hour transport, that woman looked like she had been through a long day of hard labor. So keep that in mind when we're transporting our patients. Now keep in mind that medications are synthesized through the kidneys, through the liver, and are absorbed through the gastrointestinal system. So when we think about this, keep in mind that people who have decreased kidney function have an alteration in their gastrointestinal absorption, or they have a decreased vascular flow in their liver. These people can't break down the medications, depending on where the medication is broken up in. And so they tend to have an accumulation of medication, become toxic. So that, along with liver function, decreased liver function, detoxifies, the detoxification of the blood to eliminate medications is decrease another buildup. And alcohol. They drink on top of all their medications, and the alcohol stays in their system. So something to think about. Now, typical over-the-counter medications can also have a negative effect when mixed with other herbal medications, alcohol, and prescription meds. So patients who are self-medicating with over-the-counter meds or herbal medications, we have to be real careful. That's another thing with alcohol. And an interesting point too is, marijuana. Now keep in mind, we've had legalized marijuana for a while now, but keep in mind that when marijuana was legalized, there was an increase in use by people who were in their 50s and 60s and older. And keep in mind, they probably hadn't used marijuana since the 70s, or at least the early 80s, or, July 24th, 1986. But keep in mind that, when they were that young, first off, the marijuana, the potency of the marijuana was way lower. And they weren't on all these medications. So when we first had the legalization of marijuana, we had patients that went out, used it, and had adverse reactions with the THC and their prescription medications. It was actually quite entertaining and in some cases quite serious for about the first year of marijuana legalization. So when we're talking about polypharmacy, we're talking about the use of multiple prescription medications. So having multiple medications, they can have an interaction. Now this is something they have to be very careful of, and very careful when you're examining the patient's medications. See where they're getting their medications from. Now, if they're getting them from a single pharmacy, those single pharmacies tend to have a computer program that will identify drug interactions. But if they get maybe some of their medications from the VA, they get some of their medications mail order, or down at the local CVS or Costco pharmacy, all these computer systems aren't talking to each other. So this is a condition that a patient may end up having drug interactions, negative drug interactions. And then you also get non-compliance by, of course, sometimes it's just hard for these folks to open these containers. They have either osteo or rheumatoid arthritis. Um, they can't open the containers. They have financial challenges of affording medications, to where they are either underdosing, most likely underdosing, because they can't buy it all the time. They may have impaired cognitive reasons for either taking too much or too little medications. So look for drug interactions as a possibility of a geriatric emergency. Depression is not part of normal aging, but rather a medical disease. And depression is treatable with medication and therapy. Now, some of the medications are very effective. Some need to have therapy along with them. Now, keep in mind that patients that have strong social and family ties, are active in the community, have are constantly busy, they tend to have a reduction in depression. But unrecognized, untreated, higher rate of suicide. And the geriatric population, especially geriatric males, have a higher rate and a higher success rate of suicide. So older men have the highest suicide rate of any age group in the United States. And they choose much more lethal means than younger victims. They'll go for the firearm method. They'll go to gassing themselves in a car. They'll go for hanging themselves. So, they don't monkey around with, slitting the wrists or taking a whole lot of pills. So these are patients that normally display signs of depression. So it's not inappropriate for us to ask, especially a patient that seems torpid, who seems depressed, to ask them, have you thought about harming yourself? So, and if they ask you, what do you mean by that? You say, have you thought about killing yourself? Just go straight out and blunt with it. Now, the GEMS diamond, the Geriatric Emergency Medical Services diamond, is created to help you remember what is different about older patients. It serves as an acronym for the issues to be considered when assessing an older person. So, geriatric patients. So the G, geriatric, normal aging, atypical presentation. E, environmental assessment. Look for safety. So do they have an unsafe environment? And we'll talk about that a little bit more here in a second. Or neglect. Look for your medical assessment. Look at their past history and their medications. And do a social assessment. Make sure that they have able to perform the independent activities of daily living. We refer to those as IADLs, independent activities of daily living. Can they feed themselves? Can they clean themselves? Can they do their finances? So the simple stuff, can they do that? Do they have the social network that they need to accomplish those things? So again, just to break it down again, older people, I'm just going to go right to the social assessment. Older people may have less of a social network and need assistance with their daily living. Special considerations in assessing a geriatric medical patient. Remember, you have communication issues, hearing and vision deficits, alterations in consciousness, complicated medical histories, and effects of medication. So remember your seed size up. Remember, many older people live alone. Access may be hampered if the condition prevents them from getting to the door. You may have to actually break in to a home. So take note of negative or unsafe conditions. Make sure that they have food, that they don't have trip hazards, that you may be coming back for getting them. And by the way, falls is a major cause of geriatric injury and death. So look for those unsafe conditions. Look for stuff like a lot of alcohol in the house, weapons, especially that patient who may be depressed. You know, if they have, a collection of their war weapons, you might want to get social services and to take a look at it. Again, look at nature of illness and mechanism of injury. Ask family members, caregivers, and bystanders why they were called, and listen to the patient, but also ask questions of the caregivers. They're normally the ones that are a big help. Now, let's back up a little bit when we talk about caregivers. Now, a lot of times when we think about caregivers or dealing with geriatric patients, we're thinking in the home. Don't forget that when you go to skilled nursing facilities, the charge nurse or the RN normally is not the best person always to get a good history from. You can always politely ask to speak to the CNA, the certified nursing assistant, that cares for the patient every day. They're the ones that intimately know these patients. They know they're normal, they're not so normal, where they got from yesterday to today. So respectfully, ask to speak to them and give these people their due. They're very hardworking. It's a very difficult job working in these skilled nursing facilities. Be aware of multiple and chronic disease processes that may also complicate any determination of, first off, what is wrong and what care you have to give the patient. Of course, in our primary assessment, we address the life threats. We determine the transport priority. You should be able to tell if the patient is generally in stable or unstable condition. Make sure you use that alert, verbal, painful, unresponsive scale, that AAOS scale, to determine their level of consciousness. Look for their adequate breathing. Be aware that obstructions by dentures, full or partials. Watch out for vomitus. Make sure the patient has a clear airway, clear vomitus fluid, or blood. Look for anatomic changes that affect the patient's ability to breathe effectively. Remember, if they have any rib fractures, they won't be able to breathe effectively. If they've had a stroke, they may not be able to breathe effectively. Again, the muscles on one side of their body may be degenerated or not working or atrophied for whatever reason, including stroke, that they're not able to breathe effectively or clear their airway with coughing. Again, patients could have poor peripheral perfusion, lower heart rate, or irregular rhythms that are either common to them. And remember the vascular changes that could compromise or make it difficult to either feel a pulse or get a good distal reading on your pulse oximeter. Any complaints that compromise ABCs should result in immediate transport. Now, when we talk about ABCs, remember, we're just not talking about the generalities of airway and breathing and circulation, but for the underlying issues, the difficulty in clearing the airway because of pneumonia, the inability of breathing effectively because of fractured ribs or decreased ability of muscle atrophy, or caused by muscle atrophy. circulation because of poor heart circulation. So just don't think of, the things that we think in all patients, but specific to our geriatric patients. Determine conditions that are life-threatening, treat them to the best of your ability, and provide transport. Don't be afraid to call ALS, and remember, older patients will easily decompensate. So the patient that you pick up at the scene or handed over to you by a paramedic can deteriorate en route. If you have a long transport with elderly patients, in your mind, you should also be thinking of, what if this patient begins to deteriorate or decompensate? What do I have between where I'm at now and to where I have to drop them off to get help? So if, say, you're working on Bainbridge Island, you're going to want to keep in mind that you have Station 71 in Paulsbo, Station 51 in Silverdale to stop at to get help, or help coming to you. So same if you're coming up from south. Remember, it won't be too much longer, and South Kitsap's transports are going to be take a little longer because they're going over to Silverdale. Again, find out all the medications. And when we talk about all medications, remember, they may be self-medicating with over-the-counter medications or alcohol. And make sure you get that. And also herbal medications. Make sure you get a good patient history. And sometimes that's difficult to do. Determine early whether the patient, their altered level of consciousness is acute or chronic. And the best way to do that is finding somebody who takes care of them all the time and asking them, is this their normal level of consciousness? How are they normally? And you'll be surprised how many times they'll say, no, normally they're up talking, they're fine and everything, and just today they've went downhill. So make sure you get that and make that determination. Of course, you get your sample history and transport to a facility that knows the patient's medical history if possible. And what's kind of nice is that with the electronic medical records, that the larger medical systems are very well tied in. So that works out fairly well. Make sure that the older patient is comfortable with being exposed. Protect their modesty. Just because they're elderly doesn't mean that they don't have modesty. And consider the need to keep your patient warm during the exam. Remember, these patients can cool off fairly quick. We don't want to deliver cold grandma to the EM or to the emergency department. Heart rates can be lowered because of beta blockers. So that could inhibit one of the signs of shock, which is tachycardia. If the patient is on a beta blocker, cardizem is a beta blocker, a common one that's given, they're going to be having a slower pulse rate. And weaker and irregular pulse rates or pulses are common. So again, their heart may not be as robust and beating as hard as you would expect. There'll be a stiffening in the arteries that would reduce the pulsation that we would get peripherally. And because of stuff like atrial fibrillation, they may have an irregular pulse. Blood pressure does tend to be higher. Capillary refill is not a good assessment in these patients. Again, their distal circulation tends to be decreased with age. Respiratory rate should be in the normal range. We shouldn't experience anything more. Always make sure to auscultate blood or breath sounds carefully. Remember the points in the back, the front, and along the sides. And carefully assess your pulse oximetry data. Again, if they have decreased distal circulation, you may not be getting an accurate reading on your pulse oximeter. Reassess as always. And then some of the reassessment guidelines. Keep in mind all these points. So trauma in geriatric patients, slower homeostatic compensatory mechanisms, so they're not going to compensate as well. They'll have limited physiological reserves. And of course, existing medical issues can worsen the trauma. Physical findings, again, may be more subtler or even missed. Again, they don't feel pain and they tend to have a longer healing process. Older pedestrians are more likely to have life-threatening complications after being struck by a vehicle. Older people are higher risk for burns. Again, they don't heal as easily and they can have a compromised neurological status that makes the burns not seem as serious. Risk of mortality is increased when they have pre-existing medical conditions. The immune system is weakened. Again, they can't fight off infection once they are injured, and fluid replacement is complicated by renal compromise. They cannot handle the fluid into their kidneys, so they suffer renal failure, further renal failure. They have a higher mortality rate, of course, from penetrating trauma. They have easier bleeding. Their clotting factors aren't as effective. That then becomes compromised if they're on blood thinners. Falls are the leading cause of fatal and non-fatal injuries in the older patients, and nearly half of fatal falls result in traumatic brain injuries. Changes in pulmonary, vascular, and neurologic, are more susceptible to trauma. Overall physical condition may lessen the body's ability to compensate for simple injuries, moving along quicker. Osteoporosis predisposes older patients to hip and pelvic fractures, as we mentioned before, and compression fractures of the spine are more likely. Again, these are patients who fall back on their bottoms, and it causes compression fractures, and those are less likely to heal with time. We talked earlier about brain tissue shrinking with age, so they do have that increased risk of closed head injuries. Remember, when we talk about brain tissue shrinking, we're not talking about dramatic shrinking. Even micrometers can cause this. They can have acute subdural hematomas, which are among the most deadliest of injuries, and those can tend to develop over time. So when we look at patients with decreased level of consciousness, we certainly want to ask about trauma, but don't think about trauma in just the last hour or the last days. Think about these slow subdural bleeds or intracranial bleeds that can occur and worsen over time. So again, some of these head injuries may just have a minor mechanism. They could bonk their canuncle on a cabinet, or they hit their head when they're trying to change their own oil. So something to keep in mind. Their internal temperatures regulation is slowed, so again they're more at risk for environmental injuries, in particular hypothermia, and the death rates from hypothermia are more than doubled in older people. Again, they don't have the regulatory functions with the sweating that could cause them to, get rid of heat, and the opening up of their vessels. Now keep in mind that trauma is never isolated to a single issue when you're assessing and caring for a geriatric patient. You have to look more panoramically, do a more intense head-to-toe exam, and look for not just a single injury. Even if you think it's internal, you know, you have to look for multiple injuries in these patients, multiple systems, just not the musculoskeletal system, but again, be looking for those internal bleeds of the brain and perhaps even in the abdomen. Look for clues to indicate your patient's traumatic incident that may have preceded by a medical incident. A good case in point is that guy who was changing a light bulb in his downstairs patio. He fell off the ladder, uh, shook him up. He went upstairs for his afternoon nap, and his wife couldn't wake him up. So, he basically just had a slow bleed in his head. The engine company, of course, we ask, well, what was he doing? Says, well, he's just doing some household maintenance. Go down, they find the ladder on its side and, broken light bulbs. So they're able to kind of surmise that he was trying to change a light bulb in his downstairs deck patio and fell off his ladder. So again, address life threats, determine rapid transport, as we did before. Make sure you check the airway and same considerations as with medical patients. And remember that alcohol and anticoagulant medications can make bleeding control more difficult. So older patients can more easily go into shock. So make sure you investigate the chief complaints, but also remember underlying past medical conditions that can exacerbate injuries. In your secondary assessment, of course, same manner as anybody else. Any head injury can be life-threatening, of course, and consider that breathing may be impaired. Maybe not right away, but certainly during transport. Make sure you assess vital signs. Remember, capillary refill is unreliable, and those beta blockers could be giving you a curveball on whether they're going into shock. It takes away that tachycardia that we see in shock for patients. So remember that they can decompensate rather quickly. Do not force a patient with joint flexion or kyphosis into a normal position. You want to splint them normally as is. And remember that you want to be careful when we place them on the stretcher to make sure that they're in a position of comfort. So with pelvic and hip fractures, avoid log rolling. This is where your orthopedic scoop stretcher works very well, and provide blankets to prevent heat loss. And again, provide psychological support, and certainly encourage family members to meet you at the hospital if possible. Falls can be caused by either a medical condition. Remember, we talked earlier that that syncopal episode caused a fall that was overlooked, that cardiac rhythm disturbance. Also, medication interactions. Make sure you get all their medications. Find out why they fell. Look for clues, ask bystanders, see what they fell on or tripped on. And many calls occur at nursing homes or other skilled facilities. So ask what is wrong with a patient that's new or different today. Again, be respectful and talk to the patient or the person that normally takes care of that patient. Like anything else, be concerned with infection control. Make sure that you wear gloves and eye protection, masks, and gowns if necessary. More patients are choosing to die at home rather than in the hospital. So we're going to see a lot more, and we have seen a lot more patients receiving palliative care. Remember, palliative care is care given to a patient without any expectation of a cure. So be understanding, sensitive, compassionate. Determine the family wishes the patient to be taken to a hospital or stay at home. Again, hospice nurses are normally available to answer questions, and they normally have a hospice folder at home. Look for advanced directives. These are specific legal papers that direct caregivers and medical personnel on what treatments a patient wants. Do not resuscitate orders gives you permission not to attempt resuscitation. But DNR does not mean do not treat. We still treat patients. If they have ailments that are not life-threatening or can be turned around easily, infections, for example, we go ahead and do it. Basic ABC should still be provided unless otherwise directed. Now, this is the post form. Now you'll see these in the field. They're bright green, and you really have to familiarize yourself with them. Get a hold of them, take a look at them. This is Hawaii's, but ours is very similar to this. And it has to be signed by a physician or a mid-level, so a PA, nurse practitioner, can sign these, along with the patient or the patient's medical decision maker. So right off the bat in area A, you see attempt resuscitation or do not attempt resuscitation, but then there's medical interventions, comfort measures, limited additional interventions, full treatment, and we can discuss this later in lecture. We always want to be sensitive to elder abuse and neglect. So people can be taking advantage of their person, their property, and their emotional state. It's a hidden problem in society. Most often occurs with women over 75. Abusers of older people are sometimes products of child abuse themselves. So abuse may occur in nursing, convalescent, and continued care centers. Suspect abuse when answers are concealed or avoided. Suspect abuse when you're given unbelievable answers. And information that may include or clues that you may see are caregiver apathy about the patient's condition. They don't care one way or another. They're overly defensive in their reaction by a caregiver. Caregivers don't allow the patient to answer questions. There's repeated visits to the emergency department or clinic, a history of the patient being accident prone. These look a lot like the child abuse issues that we talked about probably in the last chapter. Information that may be important in assessing abuse includes psychosomatic complaints. Patients that have psycho-produced ailments, chronic pain without a medical explanation, self-destructive behavior, sleep and eating disorders, depression, or lack of energy, substance or sexual abuse history. So some of the things we look for as far as categories of elder abuse, there's physical abuse, assault, neglect or abandonment, malnutrition, poor maintenance of the home, poor personal hygiene, and even sexual assault. Psychological abuse could be benign neglect, verbal, treating the person as an infant, deprivation of sensory stimulation, which would be either not talking to them, giving the silent treatment, no touch, ignoring them, and then financial, of course, is embezzling their funds or theft and selling of their valuables. So we look for signs of physical abuse, um, injuries around the buttock, lower back, genitals, inner thigh, face, and ears. Pressure bruises caused by the human hand may be identified by oval grab marks, pinch marks, or handprints. Human bites and on the upper extremities. We look for lack of hygiene, poor dental hygiene, poor temperature regulation, lack of reasonable amenities in the home, and regard injuries to the genital or rectums with no reported trauma as evidence of sexual abuse in the patient.